Hi everyone, thanks so much for joining us today. So this is our first Melbourne Children's Global Health Forum for the year. So welcome to everyone in the room. We're in hybrid format today, so welcome to those online as well. I'd like to start by acknowledging the traditional owners of the land on which we're meeting today, the Wurundjeri people of the Kulin Nation, and recognise their continuing connection to land, waters and culture. I'd also like to pay my respects to the elders past, present and emerging, and any Aboriginal elders of other communities that might be present with us online or in person here today. So the plan moving forward for these forums is to hope for that it will continue to be hybrid, face-to-face for that rich discussion that we can have in the room, but also the online part for people who can't join us in person, but also encouraging a lot more of our international collaborators and colleagues to be able to join and participate and hence widen our global health community. So in true hybrid format today, we've got two speakers in person today, and then our third speaker is online, who I'll introduce in a second. So if there are topics that people online or in the room here would like to see run throughout the year, please get in contact with us and we'll do our best to make it happen. Before we started though, I did just want to take a minute and pause and pay my respects on behalf of the Melbourne Children's Global Health Group and honour Professor George Patton, who you may have heard passed away at the end of last year. So as you may know, George was a world-leading adolescent psychiatrist and epidemiologist whose career focused on improving the health of young people in Australia and globally across the world as well. His clinical and research leadership roles spanning over 40 years helped develop and shape the Centre of Adolescent Health here at RCH, but also brought discussions on adolescent health front and centre to the global health table as well. Through his research, his advocacy, his multiple hats with WHO steering committees, and most recently the Lancet Commission on Adolescent Health and Wellbeing. Last month, Professor Patton was recognised in the Australia Day Honours and was posthumously awarded an Officer of the Order of Australia for his service to psychiatry, developmental epidemiology, to youth health and mental health research. The Lancet also published a lovely tribute in their January edition for anyone who wants to read a little bit more about his significant legacy, as much as it can be distilled in a couple of pages. For those of us who are privileged enough to call him a colleague and a friend, I think he'll be remembered as someone who's kind, wise, inspiration to all, but always generous with his time and thoughts, and he'll be sorely missed. So our topic today for the forum is vaccine communication and capacity building in the Indo-Pacific region. The COVID pandemic, I think, showed just how quickly our science can evolve and create vaccines, but also highlighted the inequity of vaccine distribution and uptake across the world. So the Vaccine Champions programs being presented today showcases how important community members are for community engagement and building trust and confidence in vaccines. And our speakers today are going to share their experiences and lessons learned collaborating with local stakeholders and on how to adapt the program in different countries. So I've been hearing about the Vaccine Champions program for a while, so I'm actually really excited to hear a lot more in detail today. I've seen a lot of it on Twitter, so I'm excited. As I mentioned, there's three speakers from the team today. Two of them, Margie and Jess, are here in the room with us, and our third person, Professor Thu-Anh Nguyen, is joining us all the way from Vietnam. And you can see it on the screen there. You give us a wave that you can hear us okay, Professor Nguyen? Great. I'm going to introduce them all together and then hand over the floor just to maximise the time the presenters have for us, and then should be plenty of time for Q&A at the end. For those on Zoom, feel free to post in the Q&A box and we'll get to them at the end. For those in the room, if you can hold your questions to the end and we'll have a rich discussion then. So first we've got Professor Margie Danchin, who many of us know in the room, holds many hats. She's a general paediatrician here at the hospital. She is the group leader for vaccine uptake at MCRI and clinician scientist fellow and principal fellow through the Department of Peds and University of Melbourne. She also is the deputy chair of the Australian Regional Immunisation Alliance and on the advisory board for TAGI for regional COVID-19 vaccine access. And on top of that, mother of 4 children too, so overall superwoman. Professor Thu-Anh Nguyen on the screen there is an epidemiologist and social scientist by training with more than 20 years of experience. She's the country director of Woolcock Institute of Medical Research in Vietnam, and she's an honorary senior clinical lecturer at University of Sydney. So she's been an investigator for clinical trials related to TB and management of COVID-19 epidemiology and vaccination projects. So welcome, Professor Nguyen. And we've also got Dr. Jessica Kaufman, who's a research fellow here with the vaccine uptake group at MCRI, and honorary fellow through the University of Melbourne and La Trobe University. She's our expert in communication about vaccination, and her current research focuses on strategies to increase acceptance of COVID-19 vaccines and improve routine vaccine uptake across the lifespan. So she leads the implementation of the Vaccine Champions program in Australia and the Indo-Pacific region. I'll hand over to the team now and take it from there. Thank you. Oh. There we go. Do we need to get this stuff ready? What was that? Just press OK. Yeah. Oh, I just pressed OK. Okay, fantastic. All right. Well, thank you so much, Alicia, for that lovely warm welcome. And it's an absolute pleasure to be speaking to everyone today on behalf of this group. It's a huge collaboration, and I think that is really at the heart of the success of this program, the Vaccine Champions program. And it's a pleasure to be presenting with Thu-Anh. So welcome from Vietnam, and with Jess. Hang on. So why doesn't that? How do I go forward? Ah, there we go. So as I said, this is a large collaboration, and Alicia said, you know, a little bit about some of the roles I hold regionally, and as the Deputy Chair of the ARIA Steering Committee, and I sit on the Australian Expert Technical Assistance Program, or ATAP DFAT Committee, that has really been instrumental, I think, in receiving technical assistance requests and helping to improve the access of experts in Australia to support in-country delivery of programs in partnership. And this program has been delivered in partnership in Fiji and in Vietnam, as you will see in a minute. But just also clearly want to acknowledge the role, of course, of DFAT, of the National Centre for Immunisation Research and Surveillance, and also our colleagues Julie Leese from the University of Sydney and Holly Seal from UNSW, who have really been part of the Vaccine Champions program since its inception here at the start of the COVID-19 rollout. And of course, our colleagues at Woolcock, and we've worked very closely with UNICEF across the Pacific as well, and now engaged with UNICEF headquarters in New York as well. So, as we're all aware now, at this point, there are many challenges with immunisation globally. We've had a whole-of-life COVID-19 vaccine program, essentially, which has really propelled vaccination demand and uptake to the forefront. But there's a lot of issues as well in drops in routine immunisation coverage for children. There's challenges around new vaccine introduction. And this is a serious threat globally at the moment. WHO and UNICEF have a very strong focus, particularly on zero-dose children globally, many of whom exist in across Africa, but also, you know, countries like the Philippines and Vietnam and Fiji, other Pacific Island countries also have many children who have either missed their vaccines or completely or sort of under-vaccinated as well. And of course, that makes, you know, many populations, not just children, adults at higher risk who are vulnerable to severe COVID and outbreaks for diseases like measles as well. So, but what we've become aware of is that we need different and more innovative approaches to improving uptake, and we need to think a little bit outside the box. I think one of the wicked problems that we're dealing with globally is misinformation and disinformation and conspiracy theories. And at the heart of that is trust. And that's really what this program is trying to address and work within.
So essentially, the Vaccine Champions program is a strategy to try and achieve equitable access to vaccines, harnessing the power of community engagement and communication. And really, for it to be successful, it needs to be a complete co-designed process with the target groups and populations, countries, to really be able to locally adapt the program to reach priority groups and to build trust and confidence in vaccines. And this is based on a program that we developed and delivered here in Victoria in partnership with the Victorian Department of Health, Victorian Government, led by Jess and myself, in particular with Julie and Holly as well. So just to be very clear what we mean when we're talking about a vaccine champion is a trusted member of the community, and the person does not have to be a healthcare provider or have a health background. They can be from any sector of the community, and in fact that is the real strength of this approach. So we're talking about from sporting organisations, from education, from faith-based organisations. It's really having trusted advocates and leaders within the community to be able to build confidence and address questions and concerns for COVID routine and new vaccines. And it's really about training these advocates and empowering them to be able to answer questions and also help guide people to how to access vaccines as well, and to talk about personal experiences and stories. And of course, as you can appreciate, I love this image, and full credit to Jess. It's a ripple effect. If you can just start with a kernel in a community with someone communicating about vaccines and building that trust, engaging, really addressing what those concerns are, then there's that huge ripple effect through the community where they talk to their family members, to their friends, to their colleagues, and so on. And you get this ripple effect of building confidence and trust in the vaccine that you're discussing. So the program that we started here in Victoria at the start of 2021, as I said, in partnership with the Victorian Department of Health, was really, of course, it had to be an online webinar. It was about an hour and a half, and we continually updated and tailored the program as we needed to. And it was really something that was delivered over about an 18-month period. It was probably more than 70 sessions, mostly delivered online. There were a few that were delivered in person, particularly by Jess. And there were sort of thousands of attendees that we were able to engage with through this program. And of course, key to this program as well was some of the attendees became formal champions themselves and then went and conducted some of their own sessions in their communities. And this is just a little bit of an overview of the program that we presented. It really had three main components to the program. Initially, we tried to address that pressing concern about the speed of the COVID-19 vaccine development and that no corners were cut, and to really address that concern head on, and then talk about the key vaccine safety and effectiveness data and try to balance, you know, the risk and the benefit of the vaccines and tailor it to the different population groups. Then we spoke more directly about how to promote vaccination in their specific setting, whether it was their workplace or whether it was in a specific community group or cultural group, Indigenous community. And then the last part of the webinar, the training, which was easily the part that we got the strongest positive feedback about, was role plays and training on how to have an effective conversation or how to communicate with someone who was either highly concerned about vaccinating or refusing vaccination. And Jess and I got pretty good at this little role play, and of course that's now been adapted throughout the program in different contexts. So these were the groups of people that we reached through the Victorian program. And it was an absolute privilege to be part of this program, to really have an opportunity to talk to community leaders from all of these different sectors. You can see there, you know, the police force, we spoke with housing and homeless sector representatives, lots of Aboriginal community leaders and health workers, and that was always delivered in partnership with leaders from their community and Aboriginal, leading Aboriginal healthcare providers. And you can see the different groups there. And it was just, you know, through the questions that the attendees asked, you could feel the learning occurring within the webinar, people getting more and more confidence to ask their specific question. And as I said, we tailored the role play depending on the audience. And I think people really started to understand what it looked like to really genuinely build trust in a conversation, to genuinely listen, and then to try and tailor that conversation to what the person was concerned about. And then, of course, through ARIA, so the Australian Regional Immunisation Alliance, which is a group of institutions and individuals working in immunisation across Australia, we were able to get some funding to initially look to developing this program and co-designing the program in 3 Pacific Island countries. And then, as I said, through the ATAP, the Australian Expert Technical Assistance Program, which was founded by DFAT, as part of that steering committee, we were able to get additional funding to do this program in Vietnam, and Thu-Anh and Jess will talk about how that evolved. But I've also just come back from a fellowship overseas, travelling for the last month, a Churchill Fellowship, where I had the opportunity to visit different sort of leading academic and public health organisations such as UNICEF in New York, CDC in Atlanta, and WHO in Geneva. And they are incredibly interested in this Vaccine Champions training program. It's not necessarily a new concept, but I think as we start to show more evidence of impact, and Jess and Thu-Anh will talk about that, I think it really has a lot of utility, as I said, in dealing with the incredible challenge we have at the moment with trust in different governments and public health institutions, and misinformation and disinformation. So it's an innovative approach. It's exciting to be part of, and I'll pass over to Jess now.
Thanks, Margie. So I'm going to talk a little bit more specifically about how we've delivered this program so far and some of the next steps or our next plans, I guess. So the first country that we delivered the program in last year through that ARIA grant that Margie mentioned was Fiji. And the way that the program worked in Fiji was initially we went over there for a co-design session. So we knew we had some content, I guess, from the Australian program that Margie mentioned, but we didn't know, what the priorities were in Fiji. We didn't know anything about what the content that they wanted to focus on would be, or who might be good champions. So we went over and spent a great interactive day with stakeholders in Fiji, which I'll go into a little bit more detail in a minute. And then we came back a few weeks later, and we actually ran a full 2-day training workshop with vaccine champions from around the country, where we trained them to have these conversations. And then we supported the champions for several months after that training so that they could go off into their communities and deliver information sessions and report back on some of the feedback that they were getting from their communities. And of course, throughout this process, we were doing collecting data through monitoring and evaluation process. And we used a re-aim framework. So we were collecting lots of qualitative and quantitative data around the reach and the effectiveness and the implementation of this program. So in terms of reach, the initial Vaccine Champions training program, after we had that co-design session where we had people from the WHO and the Ministry of Health and UNICEF and some faith-based organizations in the room, they helped us identify who would be trusted leaders, I guess, around Fiji. And then we invited 35 people, and you can see there we had village headmen, community health workers, some doctors and nurses, but really also a lot of people who had no background in health. So people from faith organizations, men's and women's Fiji rugby and cricket, members of youth organizations, and Fiji Red Cross. About half the participants had some element of health background, and you can see we had mostly participants from the central division of Fiji around Suva, which is where we were conducting that training session, but we did have some people who we supported to travel in to actually stay in Suva to attend that workshop. And then those champions, 22 of those 35 champions went on to run their own sessions. And the way that we supported them for this was we offered a 100 Fijian dollar reimbursement for 3 sessions. If they ran up to 3 different sessions, they got 100 Fijian dollars for each session. We had ongoing contact with them, ongoing support in terms of any resources they needed or any information that they wanted to help make them feel confident to have these conversations. And we mostly encouraged them to use group settings where they were already getting together. So they would maybe speak to their church group or a sports team or, children in schools if they had an education background, that kind of thing. And those champions ended up running 54 different community sessions, and they tracked how many people were at their sessions. So they reached more than 1,000 community members around the country. And you can see there that the average number of people in a session was 25. So that really speaks to the fact that we were, as I said, trying to target these places where people already get together, and people who they already had some sort of connection with the champion. But we also considered a session to be as small as 4 people. And in that particular example, it was someone who was from a religious community that had really high hesitancy. She was really struggling to find a way to get lots of people together or to get a receptive audience, but she had a really small prayer group. And she said, "Can I speak to my prayer group? And does that count?" And we said, absolutely. So we helped her out with some information that she could maybe share to deal with some of the more specific hesitancy that they had. And, she had a really good, productive conversation with that group. We did some evaluation before and after the actual champions training to see what the impact of the program was on the champions themselves. And we could see that it did increase their confidence to communicate about vaccines. And that's really the first step, because of course, someone who doesn't have a health background, if they don't feel confident talking about vaccines, they're not going to initiate that conversation in the first place. So everybody across all the metrics, everyone felt much more confident that they had the skills to run these sessions or to answer people's questions. And you can see there, we had some great quotes from people. I mean, one person was saying, once you become a champion, you just can't stop talking about it. Anytime you hear somebody talking about vaccines, you have to go in and talk to them. So people were really enthusiastic, and they really took this on board. The training also increased their support and their trust in the COVID vaccines and in the vaccination system and the health system. And some of the people in the room actually who were champions were people who were hesitant. So they had maybe had the first 2 doses, but they hadn't had a booster yet. And actually sitting through that workshop and doing all of the training with us made them feel confident enough to actually get the vaccine. So then we had a mobile clinic show up on the second day, and anybody who hadn't had their vaccine, pretty much all of them ended up lining up and getting that booster shot, as well as everybody else who was staying in that hotel, I think, who hadn't had their boosters yet. So that just shows really the importance of course, the Champions program and training and community engagement is so key to build trust, but you have to have accessible vaccination as well, or you can't really turn it into behavior. So that's really the benefit, I think, of having that mobile clinic available. Those sessions that the champions actually went on to run also, it's pretty tricky to get very granular data on uptake in this particular setting. We're working on different ways of collecting that in different countries, but in Fiji, we did sort of a show of hands or asking before and after the session about intention to vaccinate from the community members who were there to see the champions speak. And with that data, we saw a really strong increase in the reported intention to get those vaccines, which is great. And then one attendee actually said that now they wanted to become a vaccine champion because now they knew how great vaccines were. So I think that's that ripple effect in action. And these are just some quotes. I won't go into them in too much detail, but I just love hearing from some of the champions that, they were supported by village headmen and from different people in the communities to actually bring people together. People saying that they had evidence of a family going home after their conversation and then bringing back their whole family the next day to get the vaccine. So that's sort of seeing that behavior after that conversation, and even when people didn't necessarily change someone's mind in that one conversation, sometimes it takes a lot of conversations, and we know that, and sometimes it takes a long time. So just making sure that people were listening and feeling like they were actually making a difference was a really powerful message that we got from the champions. So the next steps in Fiji are that we have been asked to come back to Fiji by the newly elected Prime Minister has a really strong focus on increasing the booster rate in Fiji now, and really likes this program because it's this sort of friendly approach. So it's kind of able to avoid that mandatory vaccination approach that we've always seen, through earlier parts of COVID. So he's got a strong support for this program. So the plan is hopefully to be going back and doing a much more expanded version where we will actually be able to bring people in from many more of the remote areas of the country and train a much broader group of champions, also produce some materials, some resources that we can actually share with the communities when they go back to those communities. And then a second country in the Pacific that we'll be focusing on shortly is Tonga. Tonga has quite high COVID vaccination rates, but they recently introduced the HPV vaccine last year, and they've also seen a bit of a dip in some of their routine vaccination coverage for children. And so the next challenge and the next opportunity, I guess, for the Champions program in Tonga will be adapting it and identifying the right kinds of champions who can then promote HPV vaccination into the communities, or who can promote childhood vaccination, which childhood vaccination promotion is as part of the Fiji program as well, but you know, it depends on what the country's priorities are, I guess, as to what the main focus is. So we'll be going to Tonga at the end of March for that co-design session to start all over again in a new country. So I'm going to hand to Thu-Anh now to talk a little bit more about the ATAP program in Vietnam, which started a little bit differently. So it has a little bit of a different scope, but it does still sort of lead to a Vaccine Champions program in Vietnam. So I'll throw to you, Thu-Anh, and if you can just tell me when to tick to the next slide, I'll drive for you.
Thank you, Jess. Hi, everyone. So the program in Vietnam is a result of months of discussion between NC, DFAT, and Ministry of Health on what is the need of the country and how to provide the technical assistance in the most efficient way. And we focus on two objectives. Number one is to help the country to develop a targeted COVID-19 vaccine communication strategy with the focus on community engagement to improve the vaccination coverage. And the second objective is to develop a communication capacity building plan for vaccine champions involved in COVID-19 vaccine rollout, and later on could be used to improve the EPI program in general. Next, please. In order to complete those two very important objectives, we form a consortium including NC and MCRI from Sydney, working online, and luckily Jess and Belle was able to pay a trip to Vietnam. And in Vietnam, Woolcock Institute play a coordination role. We work with Ministry of Health and identify key partners in Vietnam. UNICEF is a coordination body for the COVID vaccine program in general, including communication activities. And we also work with university research institutes to identify and establish a master trainers network to actually implement this activity in the country. And in the picture on the right hand side, you can see that there are members of the consortium. And on the screen, you see the MCRI and NC who participate on the hybrid mechanism. Next, please. Our work in Vietnam has 3 stages. Number one is we review all the study in Vietnam to identify behavior and social drivers of the COVID-19 vaccination and what should be done to improve such coverage. And the next step is to design and develop a targeted COVID-19 communications strategic plan based on the finding of the desk review. And then the next step, the last step, is to develop a training program for community champions that based on the finding and the plan that we develop in the first 2 steps, but also tailor the Fiji championship training program. And that will present in further detail later. I focus on the first 2 steps. Next, please. So with the desk review, we all know, most of people know that the COVID-19 vaccination coverage in Vietnam is very high, but through the desk review, we found a low coverage of COVID-19 vaccine in selected population and areas. For example, among adult population age 18 and above, we found that at the time we conducted the review, which is mid-July 2022. A quite low coverage of the first booster dose found in some provinces, and I will present in the next slide later. And there's limited data available on the second booster dose, so it's very difficult to make any judgment about where to go to improve the vaccine coverage. Among children population aged between 12 and 17, we found that the coverage of second primary dose was very high in many provinces, but extremely low in some provinces. In one place, we found only 0.2% of the children between that age was vaccinated with the second primary dose. And the data quality in some provinces was so low that we could not make any conclusion whether the coverage is high or low. Lastly, children population age from 5 to under 12, which is very difficult not only in Vietnam but also in other countries. We found low coverage of the first primary dose as July of 2022, which is only nearly 14% of children got the vaccine. Next, please. On this slide, you can see that this is the map of Vietnam, and the province in the red or yellow are those with low vaccine coverage. On the left-hand side is the adult population, and on the right-hand side is children 12 and 17 years. If we look at the country-wide vaccine coverage, it looks high, but specifically in some places, there's a low coverage, and we use this data to provide advice to the Ministry of Health as well as to develop a communication plan that target to those geographical area and the population. Next, please. We also, from the desk review, we identify behavioral and social driver of COVID-19 vaccination in Vietnam. This slide look a little bit busy, but in general, we find a three group of theme that we need to focus. Number one is what drive people to refuse or hesitate to get the COVID-19 vaccine. The second area is the barrier to access the vaccine, even if people want to be vaccinated. And the last theme is practical issue related to the deployment of the vaccination program. And we focus heavily on the first theme, which is why people refuse to get the vaccine. Next slide, please. It's easier to look at. And the two main thing is vaccine safety and vaccine effectiveness. A lot of people think about the long-term impact on health of vaccine, of COVID-19 vaccine, or quality of the vaccine, such as expiry date of the vaccine, because there was some period that the vaccine was expired, but the Ministry of Health still want to use it for the next 6 months, or they worry about the fake vaccine or the origin of the vaccine, or the adverse event following the immunization. So a lot of people worry about that and they refuse, don't want to get even the primary dose or the booster dose. With the vaccine effectiveness, there's a lot of rumor and concern about protective capacity of the vaccine, particularly when the Omicron variant appears. And the mistrust on the vaccination program, particularly among children, whether children need to be vaccinated or not, or it will have damage on their health in the short term and long term. People also misunderstand about the nature of the vaccine, and there's a lot of rumor that mRNA vaccine is the fake one, therefore people should not take it. This is the main key finding, but we have a long report about different way people think about vaccine, and we also identify what factor positively drive people to make decision to be vaccinated. Next slide, please. From that finding of the desk review, we think that we have to turn it into the action by addressing the challenges and also take into account the positive driver to improve the coverage of the vaccine in Vietnam. Next slide, please. So the second step is to design and develop targeted COVID-19 communication strategic plan. We work alongside with UNICEF, Ministry of Health, master trainers, and community organization to develop such plan. Next, this is another busy slide. Just press one enter. Yeah, which is the first half is the finding of the desk review, and from that finding, at each box we identify what activity we should do to address the barrier, and I will present in a easier looking slide. Yeah, next one. So in the communication plan, we identify who we should target because the vaccine coverage in Vietnam is already high. We found that only people with history of chronic disease or allergic reaction are those who decline, who refuse to get the vaccine. People living in areas with low coverage in the map that I showed before. People with high level of perceived barriers to access vaccine, or they think about a serious adverse event or death following the vaccination, therefore refuse, or they have shortage of information about adverse effect provided by the manufacturers, or people who confuse about different information of the vaccine and concerned about manufacture or place of origin of the vaccine. In Vietnam, people prefer US and Europe originated vaccine over Chinese and other kind of vaccine. So we focus on that group and what information should be sent out. We think that the two most concerning issue is the susceptibility and severity of COVID infection should be focused, and the message stated by WHO should be emphasized repeatedly, which is the best vaccine is the one you can get the soonest. And we also make a plan, detailed plan about what communication activities should be done and should be delivered in a consistent manner using a scientific evidence in an adequate, accurate, and latest information. And we also need to have a plan to monitor and handling communication crisis, because we know rumor appear on an hour basis, and we have a social listening tool to identify such rumor, and the Ministry of Health has to respond to it quickly. And how to implement such plan? We identify a communication channel that should be focused in Vietnam, such as a social network. Facebook is very famous in Vietnam and send the message very quickly, and some specific online newspaper and television program that people access a lot. And particularly very important, as Maggie and Zach mentioned earlier, that the community champions could spread out the word much quicker and directly to the people who hesitate to get the vaccine, which we may not be able to access by online mechanism. So that's the end of my presentation.
Thanks so much, Thu-Anh. That's great. So at this point, I guess, am I back on screen? Okay, great. So at this point, I guess we realized, I guess when we first started working with Vietnam, we thought we might be working on communication training for healthcare workers. And that was what the original ATAP request had been. And we had this great meeting with key stakeholders, like that sort of co-design session that we've done in Fiji before. And we shared the idea that of the Champions program that we had done in Fiji, and just sort of explained it as I guess, a starting point for the discussion in terms of, is this the kind of thing you want for healthcare workers? And by the end of that discussion, they said, no, we want it for champions for the community. So it turned into a much broader program, much more like what we were already working on in the Pacific, which is really exciting. So a lot of differences in the Vietnam context to Fiji. The first of which is they don't speak English, and the materials and our training and everything were obviously very much in English. The second is the scale of the country and the scale of the program that they wanted to see implemented. The entire population of Fiji is around 900,000 people. I think Vietnam's population is something like 70 million. So it's a really different context in a lot of ways. So we worked really, really closely with the Woolcock team and the master trainers that Thu-Anh mentioned that they brought together, who were a set of absolutely expert individuals from Ministry of Health departments, from the expanded program in immunization, so immunization experts, communication experts, and university professors and things like that. So we worked together with them to really look at what we had and the content and the format of everything that we had, and to come up with a plan that might work to actually implement it in Vietnam. So the first major change is that we turned it into a train the trainers model. So while we went to Fiji and stood in front of the room and trained the champions, in Vietnam, we've added a step. So first, as I said, we had that consultation workshop with key stakeholders, including the master trainers, who are pictured in that photo. Then we had sort of the first part of phase 2 now was where the master trainers and I together kind of trained a room full of what we called provincial trainers. And they were healthcare workers from different provinces around Vietnam who have experience delivering communication and vaccination sort of trainings. They have a system already in place for that kind of information sharing, but they hadn't obviously done this particular kind of program. So we trained them in a pretty high level, but very comprehensive version of the program. So it was a one-day training, and it had an overview of the vaccines and the detail to answer questions and everything. And then we had a lot of interactive role playing and things like that, so that they could actually practice having conversations about vaccines, and also so that they understood how to then deliver this training at the next level down. And the way this worked was we did everything in English. We made all the slides in English. We had them translated by the Woolcock team, the master trainers at a translation company. We checked back and forth on that. We also had live simultaneous translation in the room when we were there. So I didn't present very much. I presented a little bit, and everybody in the room put on their little headsets, and the interpreter at the back of the room was translating for them. But most of the actual training was done by the master trainers. So you can imagine, like, they had to learn what I would normally teach, and then the provincial trainers then had to learn how to deliver the next level down, which is actually reaching the individual champions. So the way our trip worked was we delivered this provincial training session in Dien Bien, and then the next day they had lined up 30 champions to come to a room and have 4 of the provincial trainers deliver the session straight to them. So that was a little bit of a trial by fire, and they did amazingly. And so it's a slightly simplified version, but it's of the training, but it still has all of that practice and that communication, role playing and training and everything, so that those champions are able to have conversations on the ground in their villages and in their communes with people. And then the day after that, we went out to a village, to a commune, and we saw 2 different sets of champions speaking to a small group of people from the commune about vaccines, and sort of putting that information that they had just learned into practice. So it was an absolute whirlwind, and quite a lot to take in for the people who were learning and who were then implementing the training. We went in November, and the way that so this was sort of an initial pilot, I guess. Like I said, we had 6 master trainers who from a range of representative of government bodies and organizations. We ran 2 different provincial training sessions, one in Dien Bien, one in Gia Lai province, where we were actually not able to go at the last minute due to permits. So the master trainers went, delivered the session, and we were dialed in from Hanoi, watching and providing some feedback. So that was also, the master trainers did an amazing job after only having delivered the training once before. We trained 96 provincial trainers from 25 provinces around the country, which is only sort of a subset of the provinces in the country. And then they ran the provincial trainers from Dien Bien only ran 1 champion session with 32 champions, and the champions themselves came from 4 different communes, and they included people from village health workers, teachers, some people from the youth union and the women's union, and they did have a couple representatives from the ethnic minority groups in those areas. And then they went off and ran those 2 information sessions in the commune themselves, each with 10 community members on the day. So huge amount of translation, both language and knowledge, I guess, in a short amount of time. As with the Fiji program, the training, we found good increases in confidence to communicate and in support for vaccines from the provincial trainers. We were not able to collect data from the champions or the community level in this particular visit, partly just due to language issues and some survey challenges, which we're going to try and iron out for the next round. But you can see sort of the difference, I guess, of this program as articulated by some of the master trainers, really this personalized approach of understanding why someone might be hesitant and trying to work through their concerns with them in this one-on-one conversation is very different from some of the approaches that they've used prior to this. And so they identified that that was unique, and also that using people who aren't healthcare workers to share these messages. So there may be people who are less receptive to a healthcare worker telling them to do something, or they may not have as much trust, or they may not have access to healthcare workers. So empowering, as we said, more community members to share these messages was also something new for Vietnam. And the next steps for Vietnam are, we have now taken a lot of lessons from that experience. We've done a massive overhaul of all of the training materials, in particular, a couple sections that just didn't seem to land right, or were too theoretical, or just didn't really translate properly. We've had all of that now. We've updated that. It's been translated, and we're getting some feedback from the master trainers now. We are then going back over in April, and in this round, we're going to do a quick refresher to the provincial trainers that we've already trained, so that they're familiar with sort of the new materials. And we'll hold one more big provincial trainer session in a third province, in Sok Trang province. And then it's sort of, it has a mind of its own, because UNICEF has received support, and the Ministry of Health are really keen to see this program rolled out more broadly. So they have a whole plan in place to basically get all these provincial trainers running all these different sessions with champions, and then to support the champions to be doing these community sessions. And because it's such a big program, you can see that the proposed scale up is like astronomical straight away. We are really excited and really don't know quite what to expect, but I think that we've done sort of what we can do to try and make sure that all of the material and all of the content and all of the evidence is you know, packaged into this training program, and we're collecting data as much as we can. We've got a fully translated REDCap survey that we're hosting, so we should be pulling in heaps of data, and I guess sort of stay tuned. This is a real departure and a real big leap, I guess, from where we've been so far. And I think it'll be a huge lesson in terms of what this kind of work looks like if you are going to adapt it much more broadly outside of sort of the English-speaking world. So very exciting. I think that's the end of our presentation so far. So again, just want to thank all of our partners and our funders. Thanks very much. Open for questions and things now. I don't know if we have to change the settings so that Thu-Anh is visible.
Yeah, maybe can we shut it down? So you
Is that all right? I just did it. Maybe. Professor Nguyen, if you put your video back on for us. If she's still there. Lovely. I might just change the view to put onto gallery so we can share. Lovely. Okay. Thank you so much, Jessica and Margie and Professor Nguyen, for joining us online as well. I'll open it to the floor if there's any questions. And then while people are thinking, there was one comment in the QA from Kim Ma Holland. Brilliant presentation from Vietnam, so thank you. He said, please note that the manufacturers were allowed to extend the shelf lives of many of the vaccines. Many of the vials appeared to be expired when they were in fact in date. Yeah. Any comments? I mean, that sounds reasonable to do, I think. The shelf life question.
Something to explain to people, though, definitely, like that concept, I think, wasn't necessarily clear to a lot of people who were receiving vaccines, which is where the sort of misinformation around the expired vaccines came from, and the idea that they were being pushed on them because they were being expired.
Alice asked how the vaccine champions were chosen, Jess.
So the vaccine champions in Fiji were chosen in that stakeholder co-design session in the beginning, when we spoke with sort of key decision makers. They identified groups of people or individual people who they thought would be you know, well, highly trusted. So that's where we came in with the idea of the sports representatives and the faith organizations. And then we really relied on our local Fijian coordinator Louisa, and also our contacts within, within Fiji to reach out to people. And sometimes it was reaching out to the leader of an organization to then nominate someone who they would send along as a champion. In Vietnam, the champions have come partly because they have, as I said, some of them have these sort of established roles, and maybe you can add to this, Thu-Anh, but some people have roles already where they deliver health information in communes and they're connected to the local CDC. So they were invited as champions, and then other people would be invited based on what was relevant in that commune. So for us, it was, for the one we do, it was the Women's Union and the Youth Union. In another commune, it might be representatives from the ethnic minority groups or from a different organization. Is there anything else you wanted to add, Thu-Anh?
I think you capture it correctly. It's identified by the local people, not by us, but we guide them through the process on who should be selected. And also from the desk review, it was highlighted that the person, the community trust often health workers and those who have high reputation in the community.
Yeah, great. I just wanted to add, in Fiji in particular, I was so delighted to see the role of the sporting leaders. So Fiji rugby and cricket, and just the sense of kind of fun and how empowered those sessions were, and the attendees. Like, it's just so exciting to see different people communicating about vaccines and advocating, and how that message is translated, but also how the champions took it on. Oh, like, they were so excited. Maybe some of the stories.
My favorite story about it was, there was this guy named Lionel who Belle knows well. He was a representative from Fiji rugby, and he was super keen. He actually was someone who said he hadn't had the booster yet when he started the session, but was boosted by the end. And so we did the whole first day of training, and we weren't really sure what was getting through. People were really enthusiastic, but we didn't totally know if the program was landing, I guess. And he asked us if he could open the second day's session, and so we said sure. So he came on the second day. First of all, he brought his guitar and sang a hymn with the words on the PowerPoint so that we could sing along, which was really great. But second of all, he said he summarized what we had done the day before, and he put it through the language of his faith. So he was talking about how, many of us here are church-going people, and to me, being a vaccine champion is like, the city, looking to the city on a hill. We are the examples, and we lead by example, and things like that. And I just sat there going, they understood everything, and they took everything on board, and it was a full translation of what we were saying into his culture, into his community, and coming out, in that voice, which is so important. And so we saw that in a lot of different ways and a lot of different examples of it, but that just really showed me that people were picking up what we were putting down.
I also just wanted to make one other comment, and that was sincerely to thank Belle Overmars, who's our program coordinator for the Vaccine Champions program, who's worked tirelessly across all this work, but also in Fiji in particular, Kylie Jenkins, who is integral to our program, and as you said, in country in Fiji, Louisa, who's our project coordinator there. And I think for me, there are many things I'm passionate about this program, but it's this true partnership model, and how, we're just working so closely with partners and stakeholders in country, and they are essentially leading this program. It's what they want. It's really just such a fantastic example of true co-design. And yeah, just a big thanks to Belle.
Yeah. I've got a question. It's a bit of a follow-on of what you've just been discussing now, and I guess in your discussions, Margie, with organisations like UNICEF and WHO who want to sort of take it on, how do we get this message across that it's all about the local stakeholders, and how is that going to be translated, yes, on an economic model and on a global scale?
Yeah, and look, and I've had so many interesting conversations. As you can appreciate, organisations like WHO, UNICEF, CDC, they're saying, yeah, but we want to see the impact, and so it's really on us now to really clearly demonstrate impact at all these different levels, not just confidence and knowledge translation and sessions run, but actually vaccines in arms, and in the longer term, the health outcomes. So that's really, really important. But I also think there's a real tension here. You can appreciate that this is not going to be possible for every country. There's not going to be the resources to run a program like this. And there's real tension between a program like this completely run online versus this really intensive face-to-face training, which obviously we believe is a much better model and works better, but how do we make that happen? How do we adapt it? How do we resource it? And then how do you sustain it? So there's lots of challenges on us at the moment, but needless to say, WHO in particular are really keen to work with us and talk with our broader group of stakeholders about how this could be adapted for a core training for many countries globally. The CDC want to look at maybe developing this model as an in-person training, but also with an online component, because they completely, as I said, recognise challenges around funding and resourcing, and you can't always have a team, you know, like Jess and Bella and myself or whatever going in country and delivering all of this. So I think there's a lot of challenges that we need to work through. So yeah, I don't know if that answers your question.
But work in progress.
Yeah. There's a lot of thinking,
but there's buy-in
to happen.
Yeah.
I think, sorry, just to add to that, I think also the train the trainers model is really promising in terms of sustainability. And at the moment, I guess we aren't just handing off the materials without a big process of us being involved and managing all of that, because I think there is a risk that, you know, it becomes diluted and you lose some of those key evidence-based features of the training. And so that's where what we're doing in Vietnam, I think, is a really good practical practice to see if we spend all this time in investment and lots of time training and working with them, does the sustained model that they then run themselves continue to work in that way? And if so, it does make it a little bit more sustainable for other countries to sort of have that maybe heavy outlay at the start, but then you know, they can maintain it and update it and tailor it in an ongoing way.
Yeah, absolutely.
Can I just answer Anne's question, which is a really lovely question. Thank you, Anne. Everyone can see it there. I think there are lots of ways that this, you know, these messages can be delivered. And yes, there are these community sessions that are run, but there are absolutely other communication channels. We're looking at local radio in particular as a way to deliver some of these messages from the champions. And also there's another study being conducted in parallel, which is the collection of social behavioural insights data to develop resources for the champions to hold. And you know, one thing that's being led now is for the expanded booster program is flip charts for the champions to hold to communicate key data. But there's lots of other resources that I think we can develop, and there are lots of other communication channels that I think we need to explore. So it definitely isn't just confined to a sort of a you know, face-to-face session.
And in the updated Vietnam, we sort of took that feedback on board from Vietnam as well. And in the updated version, we've actually included a section where we get them to prepare a social media post, to design a social media post, or you know, and then talk about what that would look like. I just realized.
Yeah, sorry, Thu-Anh, I didn't see your hand. Go ahead.
I just raised my hand. I want to add to the response to that question, specifically in Vietnam, when the vaccination coverage is such high, like 80 or 90 or even over 90%, using social media, mass media may not work, because people won't complain of listening to all information about vaccine all day and all night, and they get tired and they against vaccination. And we found that actually, in order to target such a narrow targeted group, we need to go through their network, but not through a mass communication. And in order to find the network, for example, the elderly, we cannot use Facebook. We have to use network of people who often do exercise in the morning and use them as a vaccine champion to send the message to the elderly.
Thank you, Thu-Anh. Beautifully said.
Well, I think that's time for all of us. So thank you so much for our speakers today. A round of applause. And Professor Nguyen for joining us all the way from Vietnam. Appreciate your time. This talk has been recorded and will be online for anyone who wants to access it in a couple of weeks. But if you want to reach out to the team here, I'd be happy to pass on a message and then make their details available. Yep.
Thanks so much, Lisa.
Great. Lovely. Watch this space, I think. Back to being champions. Yeah. Thank you.
Bye, Thu-Anh.
Goodbye. Goodbye,
Thank you.
everyone.
Thanks for coming, everyone. Nice to see you.